رمضان كريم، كل عام وانتم بخير. الله يقبل منا ومنكم صالح الأعمال إن شاء الله جميعا. Our topic today is, as you know, a common or relatively common problem. We face it here because one of its underlying causes is a common condition, which is, or a common disease, which is diabetes mellitus. We have a high prevalence of these patients, and for a reason or another, our population who is affected by diabetes are, to some extent, they are not aware about certain complication of diabetes, and namely on the eye. The topic is very important, as I said, and it is a challenging form of glaucoma. But let us take some points from historical point. From a historical point of view, you know, the disease first described by, described by, if I'm pronouncing the name correctly, Bangister, and in 1871, when he diagnosed, or he described the case of high intraocular pressure in a patient with central vein occlusion who developed hyphema, and at that time he called it hemorrhagic glaucoma, thinking that the elevation of the pressure is due to the bleeding in the anterior chamber. Since then, the terminology remained in the literature for about 1 century, people using hemorrhagic glaucoma for this problem. Until 1963, when West and Schaefer and their colleagues, they gave the new term, or the most appropriate term, neovascular glaucoma, putting more emphasis on the development of new vessels on the eyes and on the angle, which always accompanied by some sort of transparent fibrous tissue, leading to the occlusion of the trabecular meshwork, and whether by the membrane or later on when it is contracted by synechia. So they gave it the name as the neovascular glaucoma, putting more emphasis on the real issue or their problem, which is the membrane, rather than which is infrequently faced or encountered the bleeding. We are not always seeing, bleeding in the new NVG. It's not always we see blood in the anterior chamber. So the main problem is, or they are trying to, Schaefer and West, trying to put more emphasis or to explain why there is elevation of intraocular pressure in patients with ischemic retina or new vessels in the iris. So this is what the Schaefer's, yes, of course, yeah, Schaefer's, and we look trying to convince or to explain to us that this new fibrovascular membrane grows on the iris and on the angle, and then leading to obstruction of the aqueous outflow. So what is the neovascular glaucoma? It is it's one of the most common challenging forms of secondary glaucomas, and it occurs when the fibrovascular membrane proliferates or grows on the anterior chamber angle, on the iris and the anterior chamber angle, obstructing the trabecular meshwork, so preventing the aqueous from reaching its normal channels, leading to elevation of intraocular pressure. This is what they said. This is whether due to synechia, even before the formation of the peripheral anterior synechia, before the contraction of this membrane, fibrovascular membrane, the membrane itself on the trabecular meshwork will block or will prevent aqueous to reach its normal channels. So then on a later stage, if not treated, this membrane or fibrovascular membrane will shrink or will contract and bring the iris to the trabecular meshwork, giving the closed angle, as you see here. So yes, this elevated intraocular pressure is most of the time difficult to control and frequently results in loss of vision totally. Even not only that, even loss of the eye. Most of the time, I remember when I was a resident, I remember the eyes that I have had inoculated is due to blind painful eye due to neovascular glaucoma. So the picture nowadays is different. See, this is a patient. You see the picture is not, I mean, so clear, but this is going to be showing the fibrovascular membrane contracting or the iris or rolling in the iris to the extent, as you see here, from UV, you see the iris processes. Usually we don't see them on gonioscopy. But here, because the iris is really pulled or ruled in to the angle, it's exposing the iris processes. So it is really a bad fibrovascular membrane and a bad disease. What are the leading causes of neovascular glaucoma? Anybody want to say something in this issue? What are the leading causes? For example, Badriya or Rihan, not Ihab, Lina Hussein, Hussein. Anybody want to see share us what is the leading cause of the neovascular glaucoma? Are you hearing me, by the way?
السلام عليكم Prof.
عليكم السلام. Layan, yes.
Hello, Prof. Sam. Leading causes mainly retinal ischemia, diabetic retinopathy.
Okay, so excellent. So retinal ischemia is responsible, as Layan mentioned, is responsible for about 97% of cases of neovascular glaucoma. Once you see a neovascular glaucoma, in 97% of cases, you need to think about retinal ischemia. The retinal ischemia, it can happen due to diabetic retinopathy, intravenous occlusion, coronary disease. These are the most common causes, but of course, there are other causes like, central retinal artery occlusion, central retinal occlusion, branch vein occlusion, and sickle cell disease, Ears disease, cost disease, ROP, retinopathy of prematurity, chronic uveitis, intraocular tumors, and radiation, and so on. So all these causes lead to retinal ischemia, and retinal ischemia triggers issuing the neovascular glaucoma. So, and how this neovascular membrane or retinal ischemia can cause this type of disease. Michelson in about more than, in 1948, he postulated a factor or vasoformative substances that are angiogenic substances that released or expressed from the ischemic retina. He doesn't know what are these substances. He called them X factor at that time. These are these conditions that lead to expression of this vasoformative substances lead to formation of new vessels, and he called X factor. The researchers spent about 50 years to look to find out what is this X factor postulated by Rangishtar at that time, the Michelson at that time. It took about 50 years from them to reach that, to discover this X factor, which is the vascular growth factor. This vascular growth factor is one of non-polypeptide growth factors. They are important or essential in regulation of the formation of the new vessels in the embryo. So their presence is very important, essential, but should be within the physiological levels. This vascular endothelial growth factor has a high specificity for the endothelial cells, causing their migration and mitosis in vitro, and new vessel formation in vivo, as well as this VGF factor, or vascular endothelial growth factor. It leads to or increases the endothelial cell permeability very markedly. Even some studies, they said about 50 times more than the effect of histamine. So it is really disturbing or affecting the permeability of the endothelial cells. So from where this vascular endothelial growth factor comes, or what is its source? Usually it's released from most of the intraocular tissues, or all intraocular tissues, expressed and produced by corneal epithelium, iris pigment epithelium, retinal pigment epithelium, ganglion cells, astrocytes, molar cells, and uveal melanocytes, as well as choroidal fibroblasts. This is usually secreted in a physiological levels that it's important for the life of the eye, and as well as the whole body. Of course, it's secreted by other cells in the body, but in relation to the eye, these are the sources, or the source of the vascular endothelial growth factor. And they found some researchers that molar cells, under certain conditions, the retina, certain conditions of the retina, the molar cells in the retina are the major source of this vascular endothelial growth factor. So it is, yes, the molar cells are the most, or the main source of the vascular endothelial growth factor under certain retinal conditions. When we look to the clinical studies, these are been reported by New England Medical Journal, and in which they look to the VGF in 210 vitrectomy samples. They found the vitreous samples taken from patient with BDR for a reason or another. It has at least 36 times more than the VGF concentration in the vitreous patient with non-proliferative diabetic retinopathy. So this is an indication of the retinal ischemia as a major cause of release or upregulation or secretion or expression of this vascular endothelial growth factor in pathological levels. So in BDR people, the vitreous concentration of vascular endothelial growth factor is 36 times than its concentration in non-proliferative diabetic retinopathy. Very clear. And again, they found that its concentration is much more in vitreous cavity compared to the aqueous concentration of VGF, indicating that the source is from the back, from the retina there. Not only that, but also they found that vascular endothelial growth factor concentration decreases 75% post PRP. What do I mean by that? For example, you have patient with BDR, and you find that the concentration of VGF X amount. When you take vitreous sample from these patients for a reason or another, when you do PRP for these patients, proper PRP, efficient and sufficient, and you have the chance to take a vitreous sample, you will find that the concentration is less by 75%. This is a very important piece of information. So they say that VEGF plays a major, they conclude, this group of people, they concluded from this study that VEGF plays a major part in the mediating active intraocular neovascularization in patients with ischemic retinal disease. So they said that, yes, VEGF is the main player in new vessel formation in patients with retinal ischemia. Good. Again, many researchers found that also that its concentration is elevated in aqueous humor of patients with NVG. Yeah. So when you have a patient with NVG, you'll expected to find the concentration of VEGF is more than a patient without NVG, indicating the process is already on and reaching the anterior chamber and or the aqueous humor. So once the researchers took 50 years to find this, what is Michelsen's mentioned in 1948, they discovered that this X factor is VEGF or vascular growth factor. So they defined this is the cause or the primary cause of the new vessel formation intraocular. So they want to try to find an antidote. And as you know better than me, they found that it was easier to find these things, Lucentis, Avastin, Elia, and others, more new things that if you give it to if you use it, you will inhibit the formation or this expression of vascular growth factor. So what is the role of PANRETINAL photocoagulation on retinal neovascularization? They found that PRP or PANRETINAL photocoagulation upregulates, upregulates expression of transforming growth factor P, which is TGFP. In the same time, neovascularization, PRP also, again, express or upregulate expression of high levels of pigment epithelial-derived factor, PEDF. And both of them, so whether PDF, how can I go back? So PRP abbreviated expression of transforming growth factor as well as the derived epithelial, pigment epithelial derived factor. So these two factors, they found to be a strong inhibitors to the VEGF. So here, yes, both. So PANRETINAL photocoagulation, one of its function is upregulation of certain angiogenic inhibitors, TGF, B, and PEDF, transforming growth factor B and pigment epithelial derived factor. These are very potent anti-TGF. Not only that, but also the role of PANRETINAL photocoagulation is, it destroyed a major resources of the VEGF by destroying or changing the hypoxic cells of hypoxic retina to anoxic retina. So major benefit of PRP is destruction of the source of VEGF. So VEGF has photocoagulation has two functions. It destroyed the source of the vascular factor by changing or by changing the hypoxic to anoxic retina or cells, and by upregulation of certain angiogenic inhibitors like TGF and BEDF. So these are the major benefits of the benefits of PANRETINAL photocoagulation. For this reason, as we'll see later, it is the definitive treatment of neovascularization in the retina and in our intraocular neovascularization. So what is the clinical picture or presentation of neovascular glaucoma? Of course, reduced vision associated with pain, and this can be expected due to corneal edema, due to, of course, retinal problems and so on, injected eye, very red eye, as you see, and highly elevated intraocular pressure. Usually, this is a clear cornea, of course. Probably this is, yeah, it is. There is a neovascularization, but also the cornea is clear. Probably the pressure is reduced, or still there is no NVG or high pressure. So, but in an NVG, usually highly elevated intraocular pressure, reduced vision, injected eye, highly elevated intraocular pressure, AC reaction sometimes due to retinal ischemia. Sorry, iris ischemia due to high pressure, and mid-dilated non-reactive pupil. Rubiosis is the hallmark of the iris. New vessels on the iris is the hallmark of the disease. Or even sometimes in 12% of cases, you may not see the new vessels on the iris or the very border, but you can see them on the angle in 12% of cases. So once you didn't see new vessels or the hallmark on the iris, don't say this is not a neovascular glaucoma. Do gonioscopy. We should do gonioscopy and to look for neovascular glaucoma, new vessels on the angle. So even sometimes in high pressure with the corneal edema, you may miss the or make observation of the NVI is difficult due to the media clarity. And also the high pressure, this is not a normal blood vessel, so high pressure can collapse these vessels to a large extent. So what is the management? The management, when we come to the management, we mentioned that, and just to review what we have mentioned, that this disease, the credit goes to Bangischer, who described for the first time in 1871, and then very important change in this pathology by his name is Michelson, who postulated the presence of an X factor or vasoformative substance that causes the neovascular formation, and researchers spent about 50 years to find what this Michelson means by that. He doesn't know, of course, what is this X factor. And they found that this X factor is vascular growth factor. So they proven that this is the real problem, or the real player of new vascularization in the eye. And then they tried to find an antidote, and they found an antidote, Avastin, Lucentis, whatever, and so on. And again, before even antidote, and before even understanding the exact pathology or the exact underlying molecule that caused the new vascularization, people were doing or treating this condition or retinal ischemia even before the formation of neovascular glaucoma by retinal ablation, whether by cryo or by laser. And this is what we were doing. I lived this type of treatment before discovering the the VGF late in 80s. And we were, the only thing in our hand is to do PRP and so on to minimize or to control the retinal ischemia, and later on to use this PRP, full band photocoagulation, also to treat the neovascular glaucoma. We spend money. We'll come to this when we come to the treatment. So what do I want to say that, yes, and before the VGF and its antidotes discovered with the treatment of retinal ischemia as by the retinal ablation, whether by cryo or laser. So the management of neovascular glaucoma, Duke Elder in 1969, he said that enucleation is the only practical treatment. There's nothing in their hands to treat eyes with the neovascular glaucoma except to remove the eye. And as I told you earlier, yes, I did some enucleation to treat a blind painful eye due to neovascular glaucoma because lack of a lot of things in our hands, whether late diagnosis or we don't have much options to treat the condition. And then this is about 5 decades, I mean. And then Grant also, he said that no means are known to prevent NVG. These are major, giant people in ophthalmology, giant authorities. So, and then Hoskins, he said that the treatment of NVG is disheartening. It's difficult. So this is, we're talking about less than 5 decades. And so, but nowadays, the outcome has improved dramatically. And this is because of the much better understanding and control of the angiogenesis, understanding of the underlying pathology, and better treatment for this underlying pathology, whether by medical or by surgical approaches. So the picture has changed, and I lived this situation. I remember in early in late 80s, and during my residency, me and Dr. Jadan and others, when we have a patient with neovascular glaucoma, we feel sorry for him that we don't have much to do for him, either to go and do cryotherapy for the cerebral body, or to do, I remember at that time, transscleral YAG laser cyclophotocoagulation, thermal mode of the YAG laser. So, and the outcome wasn't that much. Definitely nowadays, the picture is totally different. So, and this is, no, probably I'll skip this now. Yeah. So what is the treatment? How do we treat it? How do we manage patient with neovascular glaucoma? I think the most important thing is prevention. Prevention. How do you prevent neovascular glaucoma development? How can we do that? Anyone to say something? Prevention. Probably I have Layan with me. Is there anything in your mind, Layan? So you want you mean picking up the patient at risk, huh? Yeah. So recognition of patient at high risk. Recognition of patient at high risk. Recognition of patient and at high risk. So this is one of the important things to abort the development of neovascular glaucoma. Recognition of patient at high risk, and those we mean by correction of the underlying pathology, diabetes, we should control his diabetes, hypertension, and a closed observation of patient who was at high risk for NVI and NVA. So we need to observe them closely. And once there is NVI or signs of formation of, or what we call it, intraocular neovascularization, we need to do the proper treatment, which is efficient and sufficient PRP, plus minus anti-VEGF, depends on the situation. So this is the golden chance to abort the development of a neovascular glaucoma. So picking up the patient at risk. So when I examined for example, the iris of a patient with regular glaucoma or cataract, it's not similar to when I examine the iris of a patient who I know that he has risk factor for development of a neovascular glaucoma, such as patient with diabetic patient, and so on. So I need to be very careful and looking to the signs, early signs of neovascularization. Once it is there, I discover it. This is the golden chance that to treat the patient or give the patient the most appropriate treatment and prevent the development of neovascular glaucoma. So once the disease is established and neovascular glaucoma is already established, the patient came to us or presented to us with a neovascular glaucoma. My approach to this patient depends on two things: visual potential and the clarity of the media. Patient is already having this NVG, and so my approach to treat him depends on the visual potential and clarity of the media. And sometimes I forget them myself and I have to look to the time. So yeah, medical therapy, treatment is medical therapy, but as I mentioned, we're putting in mind that visual potential and clarity of media. So we'll start with medical therapy, control of inflammation and pain, by cycloregis steroids, and then medical therapy to control the IOP, by our intracardiac bronchosuppressant, topical steroids, and avoid, of course, of myotics and prostaglandin. Then, here, anti-VEGF, rapid resolution, once there's NVI and so on, or retinal ischemia, in the past, I think this is in the past, there was no anti-VEGF. So what we were doing, as I explained to you later on, we were doing PANRETINAL photocoagulation on different sessions and waiting until the NVI disappears and so on. Then we can approach if there's a need for surgical intervention. But nowadays, with the availability of anti-VEGF, you can give anti-VEGF and rapid resolution of the NVI. And so if there is any need for intervention, you can intervene. And then once you give this anti-VEGF and the NVI disappeared, you need, of course, even with or without disappearance of NVI, the patient is not going for surgical intervention, you can go for PANRETINAL photocoagulation, which is the definitive treatment, as I mentioned, if possible. And as we say, that it reduces and can eliminate anterior segment neovascularization. So PANRETINAL photocoagulation is the definitive treatment of retinal ischemia, as well as its complication, such as NVI, neovascular glaucoma or NVI, to control the disease, not to treat NVG, but to control and prepare the patient for appropriate intervention. But nowadays, with the anti-VEGF, makes our life much easier. Good. So when we come to the surgical treatment, conventional surgery, filtration surgery, tube surgery, psychodestructive procedures, and others. So let us start from the least effective one. Before that, I don't know, I think, So we mentioned that the two determinants of the intervention, our intervention in patients with already established disease. So we say that it is the visual potential and the media clarity. So here, a sketch, I did it myself, trying to simplify things. So patient already has NVG. So I have to know, is the eye is seeing eye or non-seeing eye? If it is non-seeing eye, then what I need to do is just to make the eye comfortable. By medical treatment, what do you mean by medical treatment? Red 40, atropine, anti-glaucoma medication, for example, aqueous and so on. And if this is not enough, probably I can go to cyclodestructural procedure. I don't remember that for the last 2.5 decades that I found myself in need to enucleate an eye because of painful blind eye. With this way of treatment, it is fine. So if the eye is seeing, it depends, as we mentioned earlier. Does it have a clear media or media are not clear? If the media are clear, then, as we mentioned, I don't need to wait for PRP to lead to reduction to resolution of the MVI. You can give anti-VEGF and spend 2-3 days and the MVI will disappear. So the patient having a high IOP, you don't need to wait to go for PRP. You can go and intervene surgically, whether by trabeculectomy with metamorphosis or tube shunts. And this who decide which way I should go is the status of the eye. Is there a risk, extra risk for failure of the filtration surgery, for example, pseudophakia, although it's not a big risk, vitrectomized eye, the conjunctiva has been violated. So if no, then probably, as we'll see later, I will share with you our experience in this regard. So if there's no extra risk for failure, I think the best approach is to go for trap mitomycin C. And later on, once the eye quietens down, you can go and give the definitive treatment for the retinal ischemia, which is PANRETINAL photocoagulation. But if the pressure is not that much high, for example, therapeutic disc is fine, and you gave anti-VEGF, and you can start PRP and wait for a week or two until the eye quietens down after the PRP, then you can approach your patient for the treatment, whether with trap or tube surgery, depends on the situation. If the media are poor, then of course, okay, so any question, as I heard something, if there any question, you can raise your or let me know. If the media are poor, then of course I need to give poor due to what, for example? Due to for cataract, due to vitreous hemorrhage, whatever. So and then I need to give anti-VEGF. I cannot deliver laser. So I will give anti-VEGF, the MVI will disappear, and then again, I will go for either metamycin C or tube surgery, depend on the situation of the eye or the conjunctiva. If there's vitreous hemorrhage, probably I will go and do vitrectomy with anti-VEGF also, and do laser, and then I'll wait and do the appropriate surgical intervention to control the pressure. In this case, once there is a vitrectomy, I don't think it's nice or it is wise to go for trabeculectomy. I will go for tube surgery, tube shunt. So this is just a summary when I face a patient with NVG, an unseeing eye or a seeing eye. So this is very important. Okay. So what are the modalities that are available? We said that as a surgical intervention, of course, cyclodestructural procedure, whether by laser or by cryotherapy. But the problem here is the high rate of serious complication and visual loss. As you'll see here, cyclophotocoagulation, this was in 94, visual loss up to 46 almost. Of course, this was with the old machines of lasers and so on. So nowadays, this visual loss is not at that extent because of the improvement of many things, whether the machine or the dose and so on. So it's much better, but still it's not the first option for me in a seeing eye. Cyclophotocoagulation plus anti-VGF again improves the outcome on the anti-VGF or control of the, as you will see later on in our conclusion, that controlling, I mean, the underlying pathology is the trigger for success in any procedure you're going to do. So cyclophotocoagulation plus anti-VGF, again, visual loss is up to 25%. And I think this cannot go anyhow. So you can't, because I think, yeah, this is in 2010. So this is not far away. I think I remember 2010. How this goes, yeah. Let's do this one. Yeah. So yeah, this is 2010. So cyclophotocoagulation with anti-VEGF improves, yes, yeah, visual outcome you see, and this was in 2010, which is not far away. Cyclocryotherapy, no, I don't think anybody not doing it unless in areas where there is no of lasers and so on. Visual loss up to 70%, and ptosis bulbi also to 34 as well. It is a very serious procedure. So tube surgery is another good option, especially if there's the eye is not suitable for filtration surgery. So yeah, probably more suitable for previously operated eyes like failed procedure before or high rate of visual loss. It's known to that because some people they said up to 48, and again, and the ptosis bulbi, we don't see this number. I think now things are getting much better because of better control. This is, if you see here, is 93 before the era of the anti-VEGF and so on. So nowadays, no, the outcome is much better, much better. But again, still, I see severity of filtration surgery if the conjunctiva is suitable for that, to tube surgery, to avoid extra complication that belongs to the tube surgery. Okay. Then filtration surgery. Here comes, before I go to our experience in this regard, I would like to share with you this conclusion of a paper written by Flanagan and Black or whatever. This was published in '83. I came across this paper probably in late '80s or early '90s, and this is really, it is a changing of neovascular glaucoma management worldwide. Their experience is limited to what is few cases. With a few cases, probably I don't remember, but you can take the just with the reference and go and read it. It's very beautiful article. They have three, or their case less than the number of fingers of one hand. They of cases of neovascular glaucoma due to retinal ischemia. So what they have done, I think some of them are due to BDR, others due to central vena occlusion. And that's what they have done. They treated the eyes before the era of VEGF and so anti-VEGF, VEGF and its anti-VEGF. So they treated these eyes with laser and waited until the new vessels disappeared. And then they do filtration surgery, as far as I recall. And then they followed the case and they came with this successful story in this conclusion. They say that if the neovascular element can be removed and further neovascularization prevented, then we are left with an uncomplicated angle closure problem, which should be amenable to classical trench surgery. What they want to say that you say if you control the intraocular angiogenesis, no more new vessels, and the remaining glaucoma or elevated pressure is as you should deal with it as you are dealing with the ordinary glaucoma, angular closure, primary angular closure, primary open angle, whatever. And this is really a very meaningful conclusion. I shared this with my colleague, Professor Amro, Professor Asrar. This is in early 90s, and we decided to run a prospective study to see how is this gonna help. And yes, we did it, and we report this probably more than 10 years, this article. And then I met some colleagues in international meeting. One of them is called Anan and Morfield, and he said, yes, I was happy about your report, and we started, and he reported similar results later on. So we have 30 eyes of 27 patients. We don't need to go much more in the data. The mean age was 53, and 23 was due to diabetic retinopathy, 7 eyes due to central vein occlusion, 3 eyes were pseudophakic. Pseudophakic, and the initial intercurvature was 41, ranging from 25 to 57. Conioscopy 4 were open, 18 closed, and 8 partially closed. And visual acuity ranged from hand motion to 20/40. And as I said, 3 eyes were pseudophakic. And the mean number of medication was 3 medications. The surgical technique is the same as our as we are doing now, the trabeculectomy. What I did? I leave it. Okay. So the management is a trabeculectomy as the usual trabeculectomy, nothing, standard trabeculectomy with mitomycin C. The only thing which usually and should be a habit of each one of us, that it is the gradual decompression of the eye. Gradual decompression of the eye. And this is not only in neovascular glaucoma or secondary glaucomas, but we should do it in every single eye for glaucoma surgery to reduce the pressure, not to get it up a sudden from, for example, 20 to 0. And these patients, usually old patients, would have other comorbidity problems. So it's better to decompress the eye gradually. Okay. See what I have. I think I did something wrong. What they have. Okay. No, it doesn't move. One minute. طيب فاحنا as long when I have a problem here, I don't know. So until Mona comes, so Mona doesn't move, doesn't. Okay, thank you. What you have done, huh? Secret, huh? Okay. So the standard, the trabeculectomy with the gradual decompression of the eye, and then without going in details, criteria for success is, as you see, a complete success from 6 to 21 without medication, qualified equal or less than 21 with topical medication, failure those with medication above 21. So our results after 37 months, ranging from 6 to 94, so more than 3 years, almost, or 3 years. The intracurvature was reduced from 41 to 18, and p-value, as you see, is very significantly reduced, as well as the number of medication, as you see here, and blip was present in all successful cases, and the complete success achieved in 80% of our 30 eyes, 24 out of 30, and overall success was in 90. We don't have, this is with a mean follow-up of 3 years. So we don't, usually we don't have this high figure of success in ordinary glaucoma. So why we have it in this secondary type of devastating type of glaucoma, as we mentioned earlier in the beginning of this lecture, because these eyes are under more observation, either by us as a glaucoma people or by our colleagues from the retina. So they are under closer observation, so when they need intervention, for example, social lysis, for example, those social lysis in early post-op, but for example, injection subconjunctival of vitamin C, needling or whatever. So the overall success rate was really encouraging. And yesterday we operated one case of neovascular glaucoma. We removed his cataract. I remember his functioning blip is very beautiful, controlled. Probably the surgery was done 6 or 7 years ago. So yeah, and the short-term complication is huge as usual with ordinary transient hypotony, hyphema. This is not, I mean, even extra thing. Even hyphema here, yani it's for eyes. You know, it's happening in ordinary cases. But here, in these cases, when you do decompression, slowly decompressing the eye, even you avoid if there is a residual NVI will not rupture. So yes, decompression, gradual decompression is important. Choroidal detachment, similar to the ordinary glaucoma surgery, shallow IC, oblique. So there's nothing, I mean, abnormal. Long-term complication, as you see here, sorry. As you see here, the most important thing, none of these patients, I'm not showing all the slides, the vision and so on, just for the sake of the time. So none of these eyes ended with NLP, no light perception, or hypotony maculopathy, or pterygium bulbi. And this complication, particularly this complication, is very common in patients undergoing a trabeculectomy or tube surgery in the past, before the understanding of the disease and preparing the eye in an optimal way. So cataract form progression is, yes, it is there due to the, in all filtration surgeries, we know it's a risk factor for development and progression of cataract. So in conclusion of this study, we concluded that neovascular glaucoma is a preventable and treatable condition. Anti-VEGF therapy has a central part in its management as an adjunctive therapy, temporary effect. And again and again and again, PANRETINAL photocoagulation is the definitive and prerequisite for a successful, any procedure, for a successful trabeculectomy and neovascular glaucoma. But again, I would say any procedure. If you want to have a good outcome with the tube surgery, you need to control the underlying pathology. To have a good outcome with trabeculectomy, you have to control the underlying pathology. So in summary, for this disease, it's a common secondary glaucoma, open or closed, can be open or closed. Always, there is no pupillary block in these cases. And most common causes are diabetes, central retinal vein occlusion, carotid artery disease, and the repeated gonioscopy is mandatory even in the absence of MVI in patient at risk. As we mentioned, you need sometimes in 12% or so, the MVA appears before MVI. And treating the underlying disease is a prerequisite for any successful surgical intervention, regardless what the surgery you are going to do. You have to treat underlying pathology. So this will really give you the optimal chance for success, whether trabeculectomy, tube surgery, CPC, or whatever. And this is, once you did these things, don't forget, this is one of our patients. Beautiful blip, pressure is controlled, but always look, this is patient at risk. So there's a new vessel here. So he needs to go back to my colleagues at Retina to treat this. Thank you very much. Any questions? Open the floor. I don't hear anybody. Anybody? Hello? خاف ولا احنا نخاف والله احنا نتكلم نفسي. Yes,
معاك يا بروف.
هلا معا هلا. Good. خش يا معا.
حياك الله يا بروف.
هلا حياك.
الله يعطيك العافية على المحاضرة الجميلة.
الله يحفظك ويسلمك شكرا جزيلا. A question, Abdullah Musa? Abdullah Al-Musa, yeah, this is Abdullah Al-Musa.
لا أقول الله يعطيك العافية الله يحفظك يا بروف
Allah
يبارك
يحفظك.
فيك. I think I agree with you. يعني the key thing is to prevent first, and if you have a case, not to get the patient lost and follow up and do an يعني urgent and adequate PRP.
Thank you very much, Dr. Hamza. Yes. No, why this is any other question? Why this here like that? They don't know. Huh?
You cannot do that.
Uh-huh.
The medical education is not
Okay.
valid.
Okay. Any other questions? Any comment from Abdullah, from Man, from anybody? Hassan Said. Okay. No questions. So we conclude, and we'll give you a chance to. Yes.
Dr. Saleh, I have a question, please.
Sure.
Yeah, in a setting of an acute issue, let's say that a newly diagnosed neovascular glaucoma,
Mm-hmm.
okay, and his IUP, like let's say it's 60, like in the casualty or in the setting of a clinic, okay, and he received an anti-VEGF in the course of treating the diabetic retinopathy,
Mm-hmm.
okay, and his IUP was shooting up. In this setting, can we like control his IUP first and then he received like the anti-VEGF or the PRP, or we can give the anti-VEGF at this situation?
Very good question. So your question, you have a patient with NVG, diabetic retinopathy, his pressure is 60, and how do you approach, how can I approach such a patient? This is, as you mentioned, I will, yes, give anti-VEGF.
Mm-hmm.
Yeah, and it depends, of course, I have to examine the patient to see how the disc status. As I mentioned earlier, if the disc is not bad, probably with anti-glaucoma medication, they will reduce pressure to some extent, but they will not get it. I mean, in the normal range. So I will give anti-VEGF, then I will wait for 2 or 3 days. The MVI will disappear. And then it depends on the status of the disc. If the disc is good and the pressure is now with the anti-glaucoma medication is down, probably 2/3 or so, you can go for, and the media are clear, you can go for PRP. Or even if you're choosing that to go for glaucoma surgery with a tube or trap and delay the PRP to later on, no problem with that. Now we have a better room, better chance. I remember me and my colleagues at Retina admitting the patient for 3 weeks in the floor, giving PRP and decompressing the eye through the paracentesis daily twice or so until the vessels disappears. Now, after 3 weeks or so, no, 2 or 3 days they will disappear, and then you can go and do your procedure. Or if you think that the disc stands for the current IUP, you can complete your treatment and give the PRP different sessions, and then you can have the patient once the eye quieten down after a week or so and go do your glaucoma surgery. Yes.
Okay, thank you.
Any other question?
Thank you, Prof, for this lecture. This is Mohammed Al-Khalifa. Prof, I have a question. In cases in which there is threatening tractional retinal detachment, can we give intracameral anti-VEGF, intracameral Avastin?
If there is a risk of what happen?
If we cannot give intravitreal anti-VEGF, if there is tractional retinal detachment, or in general the intracameral use of anti-VEGF agent in neovascular glaucoma, is it? Do you have an experience with it? Is it superior to the intravitreal approach, or it's the same, or it's less efficient?
Let me first of all سعيد صالح يقول انا افهم السؤال تلاقيني فرير انا عشان افهم سؤالك هذه يضحك زي النكته اقول لك سؤالك انا اللي فهم سؤالك يا دكتور مهند انه تقول if there is a risk of fractional retinal detachment, and probably the media are not clear, or the B-scan showed there is a possibility, or should say that there is a fractional detachment. Is it safe to give anti-VEGF? Is this your question? Mohanna?
Yeah, this is the first part of it.
So
And can we substitute it with intracameral?
I
rather
see.
than-
Okay. I have no idea. I have no experience. I don't think a problem. I'm not sure. As we mentioned, as we saw before, that the concentration is much more back in the eye. I don't think so. That I have no experience. I'm not aware about a real substitution, or it will be beneficial as if you give intravitreal. If you give it intracameral, is it gonna be the same effect? To be honest, I don't know. I don't know. But fractional retinal detachment, yeah, you can locate it in the B scan, and you can, I think you can choose the area where you can give the injection. And this is, you need to comment from the retinal guys, colleagues. I don't think it's contraindicated to give intravitreal FST or anti-VEGF if you can locate exactly where is the detachment. So probably Dr. Musa or Dr. Weber there can address this part of the question.
Assalamu alaikum. يعطيك العافية يا أبو. I think طبعا this case is advanced. If you have patient with already a TRD with neovascular glaucoma and no treatment before, no PRP before, this is advanced case of diabetic retinopathy. طبعا depends on the corneal clarity or media clarity. If the media is clear and there's no vitreous hemorrhage, you can proceed to pan-retinal photocoagulation without anti-VEGF. If the media is not clear because, let's say, high pressure corneal edema, and there is a TRD, then we have to enter with the patient discussion about the likely plan. Most likely the patient will need surgery, of course, for his TRD, and removing this vitreous hemorrhage or media opacity. And we can also proceed pre-op to give the anti-VEGF to prepare the eye or prepare the membranes for dissection. And also we can do at the same time, when you do the anti-VEGF injection, do a vitreous tap or AC tap to lower the IOP, plus the residual anti-glaucoma medication, full anti-glaucoma medication, Diamox, and full topical medication before vitrectomy. And after vitrectomy, if the patient still has angle problems and glaucoma, then we can refer to the glaucoma colleagues.
Yeah, the glaucoma is always, Abdullah, whether you do vitrectomy or you do anti-VEGF. And I'm not in agreement with colleagues that they said, okay, in open angle neovascular glaucoma, if you give anti-VEGF or laser or whatever, or you control the glaucoma can be reversed. Probably I'm not in a full agreement with that aspect. But the other thing that I would like to comment I want you, Abdullah, to address it for Dr. Mohanna. He said, is it possible to, instead of giving it intravitreal, when we give it intracameral, it's gonna have the same effect?
I think there will be some effect, but not the full effect, because the source of the VEGF, as you said in your lecture, Prof. Saleh, is from the vitreous and from the retina, the molar cells, the RPE cells. And so penetrating through the anterior hyaloid and through the zonules will be not as much as if you give the drug directly into the vitreous cavity.
Thank you very much. Okay, any other question, or just I leave you for your grand round? Any other question? Okay. Thank you very much.